Hi, everybody. My name is Jamie Talon, and we're here today for our PCA lecture. And we have Sara Mitchell as our guest. She's an assistant professor at University of Toronto, and she's an expert on rare dementias, and she studies behavioral dementias, language dementias, and of course PCA, which is a visual and spatial dementia. And she'll talk to us today about rare dementias and how they progressed, why they progressed, well, what scientists now know. Welcome, Sara.
Thank you so much. Can everyone hear me okay? Just thumbs up. Good. Okay, thank you, Jamie, for the opportunity to speak today. I'm very happy to be here with you and to talk to you about rare dementias. I thought what I would do is talk to you about the process from symptoms to diagnosis, and particularly highlighting posterior cortical atrophy, but also talking a little bit about other rare dementias as well. Oops. There we go. So in terms of my objectives, what I'm really hoping to do is sort of bring you into the physician side of things, the clinician side of things, and thinking about how we actually diagnose patients from the time that a patient first presents with symptoms to the time of the final diagnosis. And I'm going to do that by basically describing a patient presentation, a specific patient who had symptoms of posterior cortical atrophy, or PCA for short, just to illustrate the diagnostic process and also to sort of discuss with you considerations along the way. So we'll go on a bit of a journey. And then I'll also present a rare pathological and genetic finding in a case of posterior cortical atrophy and talk about its implications. And the reason that I wanted to do it this way is explained better in the next slide. So I'm going to start off with a bit of a conceptual framework. And this is the same slide that I use in almost any neurodegenerative talk, no matter what the goal is of the talk. And that's because getting this framework right is so important at the outset. And that's really the process of diagnosis, which is what we're focusing on today. So it starts out with the clinical symptoms. The patient starts to notice things that aren't right at home or aren't right in their day-to-day life. They may monitor it for a period of time, and then ultimately, after a while, either due to their own concern or concern from a family member or other loved one, they may present to the clinician. And the clinician has to take the symptoms in front of them and ultimately reach a diagnosis. So how do we do that? Well, what we do is we start off by thinking about what was the first symptom, and we try and map that onto the underlying place within the brain where the problem started. So we start to think about brain localization. Where was the nidus of the disease? Where did the disease start at its origin? And then what symptoms came on next? How did the disease track through the brain? And by mapping that out in our minds, we then get a sense of which parts of the brain are affected, which helps us to make a clinical diagnosis. Now, the final step of the process is to make the pathological diagnosis. And the word pathology really refers to what we see under the microscope. And that is what's actually going on within the cells of the brain. What's wrong with the cells of the brain that they're malfunctioning? And often this refers to what abnormal protein has been deposited within the cells of the brain to cause it to malfunction and to die off. So in neurodegenerative diseases, we have to look at the symptoms that the patient's coming in with, understand the parts of the brain that are involved, and then understand what is going on in that area of the brain. What is the pathology there? The reason that this conceptual framework is so important is because this is how we're ultimately going to be able to funnel therapeutics or treatments. We have to refine this process such that when a patient comes in with symptoms, we can predict the pathology with a good degree of accuracy. And at this stage, in a lot of rare dementias especially, we're not as good as we'd like to be. in this process. So we use things called biomarkers to help us refine the process. Biomarkers can refer to a wide range of mostly investigations or tests that give us clues as to what is happening in a person's brain underneath their symptoms. So in many cases, this is things like brain imaging, MRI scans, CT scans, functional imaging scans, excuse me. And in other cases, it can be things like doing a lumbar puncture, which is actually taking fluid out of the fluid that bathes the brain and the spinal cord and analyzing it to try and find certain information about what's going wrong in the brain. It can also include things that are in the pipeline, including doing things like blood tests to look at what's actually going on with the underlying pathology in the brain. So there are many different types of biomarkers. Biomarkers are things that we can really use in life when the person is living to be able to refine our pathologic diagnosis, which is often relegated to the domain of autopsy. So we're often need to see the brain after life to be able to dissect it, look at it under a microscope, and understand what's wrong. So this is the framework that I want you to keep in mind. And if you're going to take away one thing from the talk today, it should be this slide. And I'll bring it up a couple more slides. But this is really the process that we are trying to achieve in a lot of our neurodegenerative disease clinical, observational, and research studies. So we'll start off with a case. This is actually a case that was published, that I published during my fellowship with Brad Dickerson, who I know has given one of these talks previously. And it's an interesting case, and I thought I would use it to highlight how difficult this process can really be for us as clinicians and even for patients and family members in terms of understanding what's really going wrong in the brain. So this is a case of a 63-year-old man. At the time that he presented, he'd already had 4 years of symptoms that had progressed to the point that they were significantly interfering with his function. The first symptom that he had was difficulty finding objects within a complex visual scene. So he would see something like a crowded countertop like this, and he would say, "I can't see what's right in front of me." So he may be looking for the sunglasses in this complex visual scene, which he may have previously been able to pick out easily, but he no longer could see the sunglasses that were quote unquote right in front of him. This is something called simultanagnosia. Simultanagnosia is a longer term, which you'll start getting the flavor of, that we like to name things in fancy ways in neurology with lots of what we call eponyms. We name things after ourselves, and then also in terms of the fancy symptoms. So simultanagnosia is a mouthful, but it really refers to the inability to process complex visual scenes and to take out important features that need to be identified. He then developed some impaired navigation with driving. So he would say, I was going a certain route and I thought I knew the way, and I would get lost and I couldn't find my way back. He also described difficulty performing complex motor tasks under visual guidance. Things like unloading the dishwasher. So he would go to unload the dishwasher, he'd go to reach for a particular plate, and he would find that he would misreach the target. He wouldn't be able to get what he was actually trying to obtain from within the dishwasher. If he did get the right plate or the right spoon, he would then have difficulty placing it in the correct spot. And this is something called optic ataxia, which is a difficulty with completing a motor task, which is like a movement like picking up a plate, under direct visual guidance by using your eyes in order to do that activity. And this is a component of, here we go with our first eponym, Balint syndrome, which is one you may have heard about before. So the three components of Balint syndrome, two of which you've heard about in the previous slides, are simultanagnosia, which is that inability to basically perceive a visual scene in a global way, optic ataxia, misreaching under visual guidance, and then something called ocular motor apraxia, which he wasn't presenting with, but is something that you look for on a neurological exam. And as it turns out, he did have this on neurological exam, which is the inability to make a voluntary eye movement towards a target on purpose, voluntarily. So you can do it spontaneously, but he couldn't do it when asked. So when I was talking about the process of diagnosis, I mentioned that we have to start thinking about where in the brain is this going wrong. So we start to see this symptom cluster that we know has a fancy name to it, and we know that it localizes within the brain to a certain region. So just to review the brain, there's 4 main lobes of the brain: the front part of the brain that sits here, which is the frontal lobe, the parietal lobe, which sits at the back, the occipital lobe, which is the vision center, which sits at the very back here, and then the temporal lobes, which sit right around your ears. And this is the side view, kind of looks like a boxing glove. And the crease in the boxing glove I'm going to be talking a bit about, because the structures around there are really critical for some of the symptoms that he was having. Berlin's syndrome itself tends to localize within the parietal lobe, usually in the back part of the parietal lobe on the side, and often it's on both sides of the brain, but it doesn't necessarily need to be. So that's where we know his first symptoms started. Then he developed features of another eponym called Gerstmann syndrome. So this is another fancy name for a group of symptoms: alexia, which is an inability to read; agraphia, which is an inability to write; and acalculia, which is an inability to complete arithmetic. And these are features of Gerstmann syndrome, not the complete picture, but features of it. These localize to, as I mentioned before, around that crease within the boxing glove. And usually it's in this area here called the angular gyrus. So your brain is made up of a bunch of folds, basically. The gyri are the bulging out areas of the brain, and the sulci are the deep grooves that kind of separate them. So this is one that, the fold within the boxing glove is one deep sulcus, the Sylvian fissure here. And around that are a lot of important structures for higher order visual perception, and including the angular gyrus and the supramarginal gyrus, which are names for these little bulges here. He then had some unfortunate incidents. So he was riding a bicycle and he was actually hit by a truck from the right side. He was fine. He was actually completely not injured, but he was quite spooked because he didn't see the truck coming. Then he was still driving at that point. He actually hit a parked car that was on his right side while he was driving. Again, nothing severe, but he damaged a little bit of the side mirrors and scraped the car. And he became concerned about this. So he went to go get his eyes checked. And he was sent initially to an ophthalmologist and then to a neuro-ophthalmologist. So someone specialized in both neurology and ophthalmology. And they diagnosed him with what's called a right visual field defect, which is sort of what this person is seeing here, where on the right side of space, they have, out of both eyes, they have difficulty seeing. When you look at the complex visual pathways in the brain that start from the eyes and then start to go backwards into the brain, it's a lot of these parts of visual processing in the back parts of the brain that can get damaged and can cause this type of finding. Now, often these visual field cuts are things you see after something like a stroke, sometimes in the case of a tumor. But in his case, given that it was sort of a gradual onset with many other symptoms, we start to think about another type of process. What about other areas of his thinking? And those were mostly intact, aside from some language difficulties. So he had some mild difficulty with finding words. He had some mild difficulties with naming, and he also had some comprehension difficulties. And this again localizes to that same area that you've seen before around this fold here, this central fold. This is where the language centers of the brain live. There's this perisylvian hub for language. You have the Broca's area, which is responsible for speech production. And then you have the Wernicke's area, which is responsible for speech comprehension or understanding. And for him, the main issue was more here in the temporal lobe, in this Wernicke's area and surrounding regions. So you start to see the different areas of the brain all clustering together around the parietal, temporal, and sort of occipital area of his brain, mostly on the lateral side. So when we're thinking back to the localization, we're starting to think about parts of the brain that are affected. Now we need to know about other areas.
Well, they already started.
Sorry, I'll keep going. The other areas of his memory and thinking. So memory was totally intact. Executive function, which is your ability to plan and organize, was also intact. He had no new behavior or mood changes and no other neurological symptoms. And he had no past medical history that was really relevant. So this became a bit interesting now. We wanted to know, does anyone in your family have anything similar? So we asked about family history, and it turns out that his father had developed dementia at an early age, at the age of 52. Now, it was diagnosed as Alzheimer's disease, but no autopsy was ever performed. So this is actually not an uncommon story. And many people take diagnoses at face value, but if you specialize in these areas, you start to get a little bit more interested, and you start to wonder about, could there be a genetic component to this presentation? So this brings us to the question that I've sort of been alluding to already, which is, where is the lesion? Which is, if you ask any neurologist, it's their favorite question to ask. We ask it all day. We ask it about every patient. We ask it of every trainee. The first question in neurology is always, where is the lesion? And I've already told you where we think the symptoms are coming from in the brain. So now let's look at what actually we can see when we looked at his brain in life. So these are three different views of an MRI scan. And in the first two, the patient's lying on his back. His feet are the furthest away from the screen. He's looking up. The top of his head is just behind the screen. And we're chopping his head like a loaf of bread from the neck up. And this is actually the right side, and this is the left side. So it's as if he's looking at the computer screen at us. And what you start to notice is that the right side of the brain does not look the same as the left side. And the front part of the brain doesn't look the same as the back side. So what's normal? Well, normal is for all of those folds, all of those gyri and sulci to be nicely packed like this, to be tightly squeezed together and to fill out the space, the cavity of the skull. On the left side of the brain in the back, you can see there's much more space than what we would expect. So there's a lot more black, there's a lot more space. And this is what we refer to as atrophy, which is shrinkage of the brain. So if you remember when I spoke earlier about the cells of the brain getting clogged up with proteins and then dying off, when the cells die off, you get shrinkage. And this shrinkage appears as atrophy in the brain. And in his case, it's really in the left posterior areas, mostly in the parietal and a bit of the occipital areas. And if you look at it now on this view, which is the side view, the profile view from the side, you can see the eyes, the nose, this would be the mouth. You start to see this gradation in the atrophy, so that there's lots more space in the back in the parietal areas of the brain than there is in the front or in the other areas of the brain, including, the underlying structures like the cerebellum or the brainstem. Those all look nice and plump and full, but there's this gradation from front to back. So to summarize the findings in his brain, he really had left-sided brain shrinkage, mostly in the back. Now that was a structural scan. What about his functional scan? Well, and what's the importance of a functional scan? Well, I like to think of an analogy of a car. So when you look at a car's not working the way you want it to work. you lift up the hood and you can look at, actually, is there anything broken? Is there anything missing? What structurally could be wrong? But you may not find all that much. You may not get your answer. So you have to try turning on the car to see, is there actually a problem in the engine? And can we figure out where that problem is? So a functional scan is similar. We're trying to turn on the brain and see which areas of the brain aren't working as well. And so we do that in a number of ways. We challenge the brain with either on a PET scan, an FDG PET scan, we're looking at glucose metabolism, so sugar, and how the brain takes up sugar and metabolizes sugar. And that's the challenge. Are there areas that aren't metabolizing it as well? And in his case, so what are these different colors? Well, the brightest part of the brain is the part of the brain that is functioning the best. The dark means that the brain is not functioning as well. It's not taking up as much sugar, which means there's more dead tissue there. It's not as active and functioning as you'd like. So these are the parts of the engine that aren't working. And in his case, it was, again, if you look, the right side was okay. The left side, in the back, the posterior parietal areas, the temporal areas, and interestingly, a bit more of the frontal lobe than what we would have appreciated in the previous scans or based on his clinical symptoms. Now, this is a common test that we do, that certain, we can do in the States. In Canada, we do a SPECT scan, which is a specialized CT scan done through nuclear medicine, where we challenge the brain looking more at blood flow as opposed to looking at glucose metabolism. He actually had that done as well, and it showed similar findings, that there was hypoperfusion, which is decreased blood flow in those particular regions of the brain on the left side. So the next favorite question of neurologists is, what is the lesion? So we figured out where it is. We know where it is based on his clinical symptoms. We know where it is based on his imaging, but then what is it? And there's actually two parts to that. There's, first of all, what is the clinical diagnosis? What are we going to tell this patient that they have right now? And then what's the pathologic diagnosis that we predict is the second part of that. So when we think about a clinical diagnosis, this is a bit of a busy slide, and try not to let it overwhelm you, but it's just sort of my framework for thinking about dementias and rarer dementias. And how do we actually categorize them all together? So I'll take you through this briefly. When we think about dementias, we think about the most common type, which is Alzheimer's disease. And there's actually two types of Alzheimer's disease. So there's the Alzheimer's disease that predominantly affects memory, and then there's the Alzheimer's disease that does not predominantly affect memory. And that is where posterior cortical atrophy comes in, because it primarily affects vision. The other two non-memory subtypes of Alzheimer's disease are a language subtype and a frontal subtype. And why is it all under Alzheimer's disease? Well, again, this refers more to the underlying pathology, which is specific in Alzheimer's disease. In Alzheimer's disease, it's particularly two proteins that are deposited within the brain, amyloid plaques and tau neurofibrillary tangles. Then there's vascular dementia, which is sort of its own little bucket. It's due to microvascular changes within the brain, so small little blood vessels getting clogged up. There's frontotemporal dementia, which is a process predominantly affecting the front and temporal lobes of the brain, which can present in two ways, either with predominantly language problems or behavioral problems. And then there's the Parkinsonian plus syndromes, and those are people who really have more mobility issues as their main problem. And they sort of are cousin diseases of Parkinson's disease, of which there's many different subtypes: cortical basal syndrome, multiple system atrophy, Lewy body dementia, progressive supranuclear palsy. And so this gentleman was thought to have posterior cortical atrophy, and that's because he had slowly progressive symptoms over time that were very targeted to affecting the higher order visual spatial function. So the most recent consensus criteria that we use are from 2017, and they require you to have 3 of these long list of higher order visual processing issues, and I highlighted in red the ones that he did have. So he very well met the clinical criteria. But the other thing to remember is that there should be sparing of other functions. So memory should be spared, speech should relatively be spared, non-visual language function should be spared, executive function, behavior, personality. So sometimes people get confused because patients can come in with a whole host of symptoms and you can't figure out what's what. But then you think back to what I said in the first slide, which is where did the disease start and what were the predominance of symptoms early on? And that's the case here, consistent with posterior cortical atrophy. And I call it the phenotype, which is a term that comes from genetics, which really means what is the constellation of symptoms that the person's presenting with in life and how can we clinically diagnose them. The term posterior cortical atrophy was coined by Benson to refer really to that peculiar pattern of shrinkage of the brain that I showed you on the MRI, affecting more the back part than the front part. And this I found an interesting graphic, which just shows the higher order visual processing issues of someone with posterior cortical atrophy, in which you may be looking at this is just looking at visual tracking. So it's tracking where a person, when they see a complex visual scene, like that countertop that I showed you initially, that he was having trouble finding his glasses, how does he actually go about looking within that scene to figure out what's important? And, oh, sorry, this should not say PCA patient, I apologize. This is the PCA patient. This should actually say normal. Apologies. The number A is normal. So they may focus on the salient aspects of the picture. So all the people and everything on the bridge. Whereas someone with PCA will start focusing on things like the sky. They might look at the ocean. And their ability to grasp the complexity of the scene is limited. And in this case as well, his age fit with what we know about patients with posterior cortical atrophy, which is that they tend to present earlier than Alzheimer's disease, typical Alzheimer's disease, in your 50s and 60s. And that's patients with typical amnestic Alzheimer's disease affecting memory. So then becomes the question of what is the lesion? So what is the pathologic diagnosis? And I'll bring us back to this clinical framework. So we've talked about the clinical symptoms, we've talked about where they localize in the brain, but what is the pathologic diagnosis and why is it important? Well, it's important because we need to know how we actually finally diagnose this person. And that's how we actually funnel people towards clinical trials and therapeutics as they come in. And the harder time we have in predicting that, the harder time we're going to have in treating these diseases long term. So we need to be thinking about the pathologic diagnosis. So what are the abnormal proteins deposited in posterior cortical atrophy? Well, as I showed you on that classification scheme, posterior cortical atrophy is really thought to be a subtype of Alzheimer's disease. And as I mentioned, Alzheimer's disease is really defined by amyloid plaques and neurofibrillary tangles. And about up to 80% of patients with posterior cortical atrophy will actually have Alzheimer's disease pathology in the brain. Other pathologies have more rarely been reported, of which there are a few different ones that have been reported. So our prediction would be that this patient actually had Alzheimer's disease in their brain. So what did we actually see? So this is the autopsy of this gentleman that I've presented to you. This is what his brain looks like grossly. So just when we take it out at autopsy. And this is just what can we observe? So we're looking at those same folds, the same things that we were looking at in terms of the MRI scan, but now we're looking at the gross pathology. This is the right surface of the brain on the side, and this is the left surface of the brain on the side. And you can see those same findings, the shrinkage of the brain, the increased space between the different grooves in the brain. Everything is more tightly packed here. There's much more space on this side. And this is looking at the undersurface of the brain. So from here, looking up. And again, you can see the right side compared to the left side. There's much more atrophy on the left side of the brain. Okay, so then what did we see when we actually looked at the brain under the microscope? Well, you're probably saying, well, what am I looking at? Why should I even be looking at the brain under the microscope? Well, it's because it does become important to know what the ultimate diagnosis is. So this is looking at different areas of the brain sliced really thin in different parts of the brain, including the front part of the brain, the frontal cortex, the parietal part of the brain, the occipital part of the brain. And what you can see actually is that the cells of the brain, these little dark purple dots, are actually very far apart from each other. They're much more far apart than we should see. And that's because they're not tightly packed, because so many of them have died off. And there's lots of extra areas of what we call gliosis. Gliosis is basically scar tissue. So when the brain dies, when brain cells die off, it just gets filled up with kind of scar tissue like you would get in other parts of your body. And then we went to stain the brain for Alzheimer's disease pathology to look for amyloid plaques and tau tangles. And lo and behold, we didn't see any. So what do we do in this case when we don't find what we're looking for? Well, we go back and we think about that classification scheme and think about, well, can we start staining for other rare pathologies, for other abnormal proteins that we could see? And so they started to do that. And lo and behold, they found something called TDP43. So TDP43 is a name for a particular type of protein that's deposited within the cells of the brain in frontotemporal dementia often. So if you remember, if you go back to that classification scheme, which I'll go back to in I think the next slide here, you'll remember that PCA was over here, but frontotemporal dementia is over here. So we weren't expecting this finding. And what was even more interesting is that the way that it was shaped within the cells of the brain was unique. So it looked like a little needle. And when you see these kind of needle-like inclusions within the brain, we actually think about a genetic cause of this finding. And posterior cortical atrophy is usually not genetic. So this case became really interesting. Now, I just wanted to take a moment to go back and tell you why we don't think that this was frontotemporal dementia in terms of a clinical diagnosis. I mentioned it very briefly, but I just want to review in terms of other rare dementias what those could have looked like in terms of symptoms. So the behavioral variant of frontotemporal dementia, remember there are two types. So there's behavioral types and language types. The behavioral types, you have to present with predominantly behavioral change. And what does that look like? It looks like apathy, which is just a lack of motivation, a loss of interest, disinhibition, which is basically when you are not able to hold back certain comments that you would otherwise choose not to say, and you may be offensive to other people. Losing your sense of sympathy or empathy for the people that you love, certain types of obsessive or compulsive behaviors, and certain types of eating patterns. And again, that's particular atrophy pattern to the frontal and temporal lobes of the brain. The other two types are types of primary progressive aphasia, which is primarily problems with language for the first 2 years of the illness. And it can either be difficulty with producing, difficulty with understanding word meaning, which is the semantic type, when you still have fluent speech, and that affects that anterior temporal part of the brain here, or difficulty with word production, which with non-fluent speech. So he didn't have any of these other rare types of symptom constellation. So this now became a very interesting finding. With the frontotemporal dementias, those different types that I described, about half of them will have TDP43 pathology, the other half will have tau. And there's different types of TDP pathology. So this is what we found in this gentleman. So what happened to him? Well, he developed some worsening of his visual spatial function. He developed what's called apraxia, which is an inability to perform skilled motor movements. He had progressive difficulty with language and increasing behavioral symptoms. So as the disease progressed, it went on to involve other parts of the brain. He was treated with a cholinesterase inhibitor, which is a medicine that we usually give in the context of Alzheimer's disease, because in up to 80% of posterior cortical atrophy, the underlying diagnosis is the same as a memory predominant Alzheimer's disease. So we give the cholinesterase inhibitor. Now, what's interesting is that cholinesterase inhibitors can actually make behaviors worse sometimes in frontotemporal dementia. So we didn't know his underlying pathology when he was treated with this, and maybe in retrospect, it could have made some of the behavioral symptoms worse. He worked quite extensively with occupational therapy and speech language pathology to modify his environment, to work on communication strategies. And he ultimately died 9 years after the symptom onset. When we looked at the brain and had those interesting findings, we decided to, those little needle-like inclusions that I showed you, we actually decided to test genetically, and we found a progranulin gene mutation. Progranulin is just a name for a type of gene mutation, which shows that it actually was inherited likely from his father. So this was a genetic case. And posterior cortical atrophy is usually not genetic. So this is a really interesting finding again. So how do we conclude? What's the bottom line from all of this? Well, the reason I chose this case and this process is because I really wanted to explore with you the diagnostic challenge that we face, both as patients and as healthcare providers, in trying to really provide final disease confirmation as to what is going on with a person from their symptom presentation to the time of final diagnosis. Refining that process of diagnosis is really important for developing treatments. And so the more we can learn from our patients and the more that the patients can teach us, the better we will do in trying to advance the disease. So it becomes a partnership, it becomes a process. And so participation in things like observational research studies can really help in our process of advancement in the treatment of rare dementias, because it allows us to think through this process even more extensively and improves our diagnostic abilities. And I just want to conclude with this slide, because this was really true in this gentleman, that the relationship between a patient's symptoms, the pathology in the brain, and their genetics is likely very interactive. All three of these things co-occur and they interact with each other. And that's ultimately what produces many of these rare variants of certain types of dementias. And that's it. Thank you for your attention. I hope you stayed with me, and I would be happy to answer any questions, and I invite any conversation you may have.
Well, thank you so much, Sarah. That was really interesting. I will take questions, and if you want to have a question, you want to unmute yourself, since there are a number of people I can't, I'm kind of looking down on the.
I'll do it.
Okay.
Jamie, I had a quick question. Thank you for the presentation. That was great. Much of what you presented sounds a lot like probably a lot of people heard, but what Carmela's diagnosis sort of progressed through until you got to the punchline with the different diagnosis. And I was curious whether that patient had a CSF showing tau and amyloid, or, you know, you said in the autopsy it didn't, but whether the whether you had done that test and it showed positive on that.
I'm trying to recall. I believe we did do the test, and I believe it was negative. I have to go back to the case report to be certain, but I believe that we did do it in life, and I do believe it was negative. Now, that is a very helpful test if we can do it, because it does give us a sense. It's a very good biomarker, right? Like going back to that slide, to tell us about and inform us about the pathological diagnosis. It's not a perfect test, you know, we still can get it wrong even with it, but it certainly has improved our diagnostic abilities. It's interesting because in Canada, we basically can no longer get it done. The government doesn't fund it, but in the States, I imagine you're still doing it quite frequently. And it's a very good test that can be done in life to help glean the underlying diagnosis.
Okay, that's good, because yeah, we had that and it was positive, so I just was, so
yeah.
it would certainly lean more towards that being the pathology then, right?
Absolutely, yeah, absolutely.
Okay. Thank you.
Interesting. Thank you so much, George. Anybody else have any questions? You can unmute yourself. And I'll look quickly down. Anybody on the phone? Well, we can't see you, but if you have a phone, you can unmute yourself and ask a question. And if nobody has a question, I'll ask a question. So he was 4 years into it before he showed up at your door. And we know this disease is progressive. So how do you know that those were his earliest symptoms?
Right. So that becomes the art of the history. And if you go to see your doctor for the first time for a diagnosis, especially if you go to see like a cognitive neurologist or someone who specializes in rare dementias, the amount of times that they might review, when did that symptom come on, you know? And it can be hard because it can be hard for patients. It can be hard for family members to say, when did that actually start? Because it's not like you wake up one day and all of a sudden can't. That's the thing about neurodegeneration. It's a slow, grumbling, gradual process. And by the time you realize that you can't, you probably haven't been able to for a while, but you haven't been able to put your finger on it. So it's certainly not a precise science. It's definitely a bit of an art, you know, the art of medicine, when we try and get different aspects of the history in different ways. And the timeline becomes incredibly important. And that's why a lot of what we do with our trainees is trying to teach them how to determine the timeline, because it is so important. And many of our diagnostic criteria rely on it, because by the time patients come to the forefront, as you say, many symptoms may have developed, and it may be too late to really, based on that moment, to be able to make a diagnostic impression without getting that clear timeline. And sometimes we just don't have it. I mean, sometimes it's just not available based on, you know, there isn't enough factual information. And then we can just go with that, what we call cross-sectional assessment, just that one time point, and make our best diagnostic impression based on that.
It's so interesting. What does progranulin gene mutation do? I mean, what?
Yeah, so basically progranulin is, it causes what's called a haploinsufficiency. So it's basically the protein is, it becomes malfunctional. It causes a change in the function of the underlying protein, which then from the progranulin mutation causes the change in the underlying protein of TDP43, which is what we found, which causes the abnormal inclusions. So in most cases of genetic progranulin mutation, you'll see TDP43 as the underlying protein accumulated within the cells of the brain.
Interesting. Does anybody have any other questions? Yes, David.
Yeah, Sarah, thanks for the presentation. What's always a little confusing at the time, and even in your presentation, you say non-memory when you take PCA down, but actually like Shirley's case now, she's been diagnosed for almost 6 years now, and memory loss is really becoming more of the issue. So really, when we tell people about PCA, it seems like the first few years is the visual, but really memory now has really become more of the issue. And I mean, her vision's kind of leveled off to where, you know, it's not as noticeable the changes, but definitely the memory now has really become very evident. Yeah. So I guess the bottom line is, when we tell people about the disease, when we say non-memory, it really is not, except for the case you presented, but I think more people are falling into the category where the memory loss does become an issue after so many years.
Yeah, thank you. That's a really great point. I think, you know, we tend to try and simplify things for the purpose of classification, but obviously, first and foremost, patients don't always cleanly fit into our predetermined categories. And second of all, because it's a neurodegenerative process, it's certainly going to progress over time to not just be isolated to that region of the brain, right? So it's not just the visual part, it goes on to have many other symptoms. And memory is a very common one, especially because the underlying pathology, the amyloid and the amyloid plaques and the neurofibrillary tangles, clearly there's something about the memory structures that they like. There's some sort of, propensity for that area. And that's one of the things people become interested in, is why do certain proteins like certain parts of the brain, and what's the interaction with the genetics. But memory issues in PCA is certainly something that we see. And although we often classify it as a non-amnestic type of Alzheimer's disease, that's just usually due to the presenting symptoms. And over time, it's important not to underestimate the effects that the eventual memory symptoms can have on a patient's quality of life and a patient's progression.
Got it, David?
Thank you.
Any other questions? Yes, Kathy.
Yeah,
Doug,
yeah, actually,
hold on.
okay.
Go ahead, Kathy. Go ahead, Kathy. We can't hear you. You want to type out what you want and I'll get back to you? Maybe because your headset's on. Norm, did you have a question? Comment? No? Somebody else
Okay.
did.
Doug does.
Doug does. Go ahead, Doug.
I had a business and it was a lot of cleaning things and lye, for instance. Not lying to you, but I wonder, it was all done with very hot water and everything like that. Could that be inhaled, and could that be part of what could be damaging things? And
I think it's a good question. I think there's a lot about environmental exposures and toxins that we just don't know enough about. We know that there's some combination of a person's genetic predisposition combined with, so their genetics that they're born with, combined with, their environmental exposures, or what happens to them throughout life, what they are exposed to. Why certain people might develop it earlier or in certain ways. And it goes back to sort of that last slide that I have, that there's such an interaction between all the different factors, and that's why it presents so individually in different people. That being said, we don't have good studies to prove one way or the other. I always ask about toxic exposures. I always document them and look for patterns and think about it, and as do many other clinicians and researchers. But there aren't any hard associations that have really been proven, especially, the ones that you described that would clearly show a causation between an environmental toxin and the development of the abnormal pathology.
but if I would imagine you wouldn't know whether it was going to be possibly for some of it to heal a little bit, or is it pretty much just that's where we are?
You mean once the pathology is already there?
Yeah, once you realize, what all is done, and
Yeah.
you're finding this all out.
Yeah.
Are there proteins and things like that you can check to see if they're changing, but
We're reversing this situation.
Yeah. I mean, that's the $1 million question right there. You've hit the nail on the head. I mean, how do we actually treat this? How do we reverse what's happened in the brain? We have not been successful to date with disease modifying therapies that actually change the course of the disease process. And I think in part it's for two reasons. One is because of the process that I described today, which is why I wanted to describe it, which is that we don't have the right people in the right studies. And so, someone with this could be given Alzheimer's disease drugs, which don't work. But because we don't have a good way of testing what we're actually treating, then everyone gets put together. And then the second is that we probably aren't giving it early enough. A lot of the medications or therapeutics that we have, we know that people start to develop symptoms decades after the proteins deposit in the brain and the abnormal pathology is already there. So intervening in the prior to symptom onset period or the asymptomatic period is really what we need to be doing. But as you can imagine, that's hard. It's hard to get that population. People are trying to do that by looking at genetic carriers, so people who have genetic mutations, and we know they're going to develop the disease. And so, you know, can we give them certain therapeutics to try and prevent the onset? But, you know, that's sort of a roundabout way of saying that we don't have a way to reverse it at the moment. The focus is on maintaining brain function. So there's many things that you can do to try and, on a day-to-day basis, keep your brain in the best kind of brain health state and try and keep it resilient, including things like diet, exercise, stimulation, and then also all the things you've been doing up in your life up until that point, or what we call your cognitive reserve, which is all the things that you've been doing, your education, your occupation, your intellectual abilities, all the things that you've been doing your whole life, your vascular risk factors, that kind of create this resilience package against neurodegeneration. So there are things that you can do, but we don't have the golden ticket yet.
Great. Well, thank you very much for that question, Doug. And anybody else have any questions before we? Yes, Barbara.
I found this very interesting. Thank you for the presentation. Probably I have to hear it many times to be able to remember it. But you talked a little bit about genetic components and not necessarily with PCA. But Carol's father had Parkinson's and her mother had ALS.
Yeah.
And I wonder if, well, she has PCA. I wonder if there's any kind of relationship there.
It's a really good question. We're learning all the time about genetics. I mean, genetics is fascinating and it's a rapidly growing field. We know that, you know, ALS can occur with certain types of rare dementias, particularly frontotemporal dementia. And we've just recently discovered the gene that explains the co-occurrence between those two. So when we see clusters of neurological diseases like that in families, you know, a motor neuron disease like ALS, a movement disorder like Parkinson's disease, and then a rare dementia like PCA, you know, often that'll perk up a clinician's ears to think about, well, could there be a genetic explanation? Either one that we've already determined that we can test for, or that we can discover through whole exome sequencing or full genetic analysis of the individual, and if even better, if we have a whole family. So definitely a good thing to be thinking about, to be asking your clinicians about. And, you know, often we look to the help of genetic counselors to help us sort of piece things together and lead that process. But ultimately, you know, the genetic testing could be pursued if there was high enough suspicion.
She has a brother and sister, and neither one of them have any neurological diseases.
Right, which, you know, is not necessarily here or there, because the patterns of genetic transmission aren't always, you know, they go to every person, right? They can just go to one family member, they can skip a generation. You know, there's autosomal recessive, autosomal dominant, there's X-linked. So there's different ways that the genes can pass along that can spare certain family members and affect others.
Thank you.
Thank
Jamie,
you.
Jamie,
Yes.
can you hear Kathy now?
Yes, go ahead, Kathy.
Oh, thank you. I just have kind of a little anecdotal thought.
Great.
My husband is his vision has actually not been the predominant problem with his, with this progression of the disease. His is his functionality, being able to figure things out. But we have a Kleenex tissue box that sits on the kitchen table all the time, and he can be sitting there and he can be using the tissue. And then all of a sudden he'll say, could you please give me a tissue? And so the brain, is obviously something has occurred. But then he'll look down on the floor and he can see a speck of lint or he can look at the TV and he can hone in on a word. He can read the word from across the room where I can't because I need cataract surgery. But then, he can't see things that are on his left side, but it's kind of like his brain goes in and out of functioning.
It's interesting. Thank you for the observations. I think one of the things that's most fascinating is that picture that I showed with the beach scene, the sort of the pier. And you look at, the way that someone approaches looking at a complex scene. And sometimes the eyes might fall directly on the target, directly on what they should see. And sometimes the eyes might fall so far away from it that, there's no real comprehension. So it is sort of a random process of how the eyes are interpreting the scene and what may ultimately come out of that, and how sometimes it can be precise and perfect and other times it can be so off base. But that kind of fluctuation is not uncommon in terms of clinical presentations. It's extremely interesting. And in some ways it can be frustrating, right? Because you think, well, how can you see that and not see this? But, it is sort of a testament to how complex the functioning of the brain is, and in turn, how complex the dysfunction of the brain is as well when it's not working.
Wonderful, thank you. We have a question from Andrea. Do you want to unmute yourself?
Sure. And please disregard babies, toddlers, dogs, whoever else.
Like those sounds.
And I will try not to be too complex here, but so I would say we've been noticing symptoms in my mom since probably about 2014. So she's fairly progressed with PCA. And the visuospatial and the visual problems are, undoubtedly there. But the personality also has changed and really declined almost concurrently with the vision, to the point that, as a matter of personality, she's unrecognizable. It's not the woman that I knew, 8 or 9 years ago. So what you had said about the frontotemporal dementias really kind of struck with me as well. And then your case study was really unique in that it was mistakenly diagnosed as PCA. And you mentioned about the cholinesterase inhibitors kind of being problematic, in the wrong setting or in the wrong diagnosis. So is there any benefit to removing those if you suspect a different type of dementia? Or in our particular case, as far along as we are in this journey, my mom has never had like invasive testing, CSF testing. I think she's probably had a basic like CT with contrast. I'm in the States. But yeah, nothing more than that. Is there any benefit to that, to giving a more clear diagnosis? I feel like she's only ever had one physician that she's seen, one neurologist, and he just personality-wise seems pretty laid back. So I've often questioned in the past 5 or 6 years that we've been following with him, was there anything we could do more aggressive in terms of diagnosing or even treatment-wise? So yeah, I don't want to make it too complex, but I was just wondering about with those really prominent personality issues as well, would we be harming anything with these cholinesterase inhibitors? And should we should we go for any more testing?
Yeah, so thanks for sharing all of that. I think that, ultimately it is going to be a conversation with your care provider about sort of the risks and benefits of investigations, of trials of different medications. In a lot of cases, it is trial and error. And, what I would say is with the behavioral symptoms, again, in terms of diagnosis, it depends when they came on. Was it really early on, or has it just become more of a predominant feature later? But, the cholinesterase inhibitors are symptomatic therapies at best, and they're certainly reasonable if the clinical diagnosis is posterior cortical atrophy. But if there's some concern because of the predominance of the behavioral symptoms, I mean, this is a really rare variant that I presented, so the likelihood is pretty low. But if there's some concern, you know, you could have a discussion with your care provider about either doing, you know, just a functional scan of the brain or an MRI to get more information to make a decision, or even just doing a trial off of it to see if there's any change for the worse or better. So these are kind of the complex decisions that you would make in partnership with your care provider to decide, you know, how could you optimize quality of life and really try and improve the symptoms best you can with you know, the medications that are available.
And are there any major risks for removing those medications? It's something that's been standing for so long. She's been on those for probably 4, maybe 5, probably about 4 years, I would say she's been taking those medications.
Yeah, so sometimes people who have been on cholinesterase for a while, they'll say, you know, the patient's worsening, they're not doing anything. And then you take the medication off and you see that they're actually, the medication is doing something because they get a lot worse. So sometimes you can't tell until you take the medication off, but then it's as simple as starting it back. It's not like, you know, you get a huge decline and you'll never get back to that point. So again, it's a bit of a trial and error with your clinician, but you know, it can give diagnostic information as well as to whether or not the medication is helping and working.
Thank you.
Pleasure.
I have another question.
Yeah.
The case that you presented, the man had a right field problem, and Carol has a left field problem. Is there any difference in?
Yeah. Yeah. Well, when you have a right, so the left side of the brain controls the right body and the right visual function, and the opposite is true. And what's interesting is actually that your case is much more common. So it's much more common that the person with posterior cortical atrophy will actually have right-sided pathology and a left-sided visual field issue and associated visual problems. This case was rare for a number of reasons, and you just picked up on one that I didn't highlight. But again, I think it goes back to that last slide, that it was probably some combination of the genetics. So the genetics, you know, caused it to be such a different presentation and location within the brain. So that would be the main difference. It's just that in your case, it would be the more common presentation. I think, Jamie, you're muted. I can see you're talking, but you're muted.
I'm going to unmute myself. My dogs were barking. So, Sara, thank you so much. You were terrific, and this is going to be recorded and will be available for anyone to hear. Andrea, you can also share this talk with your mom's neurologist. That, you know, might help. A lot of neurologists don't know about these atypical dementias and maybe have only seen a handful of these cases throughout their whole career. So it's always good to educate them as well, and including ophthalmologists if you know, you're taking your parent to an ophthalmology appointment and you think that there's something else going on. So thank you. You were terrific.
Thank you
and
so much.
Thank you, everybody, for joining us today.
It was a real pleasure. Thank you, everyone. Thank you for having me. And it was so nice to speak with all of you. Feel free to email me.
Thank you.
Bye.
Bye, everybody.